Good afternoon, everybody. This is Tom Keane from the Medical University of South Carolina. I'm going to be discussing androgen deprivation therapy as it relates to bones and hot flashes, and also its use with chemotherapy and timing. As we look at androgen deprivation therapy in general, there's a lot of sexual dysfunction which I will just mention, but I should point out that not alone is there sexual dysfunction present with ADT, but there are also a number of other things which you see listed on the slide in front of you. There's significant weight gain, there's gynecomastia, loss of libido, loss of body hair, hot flashes, which you will discuss in more detail. There's also bone alteration, and you can see there's numerous different complications, which some are related to primary therapy, some to androgen deprivation therapy for prostate cancer, and then we have some that are shared with both. Some of these strategies, and there are many, which have been undertaken to mitigate the side effects of ADT, would include intermittent timing of ADT, in other words, stopping and starting, reducing the duration of ADT, anti-androgen monotherapy, and also exercise therapy. Now, intermittent ADT has been shown to result in improved desire for sexual activity compared to continuous ADT. However, this is only a viable option for men with a rising PSA and after local therapy without evidence of metastatic disease. Also, reducing the duration of ADT can result in significant improvement in sexual function and activity when comparing 6 versus 36 months of ADT with high-risk locally advanced prostate cancer. However, there was an increased risk of mortality in the reports which were published, and as such it cannot be really recommended. There is a randomized controlled trial of leuprolide versus bicalutamide, which found less of a decline in sexual interest in anti-androgen monotherapy alone, but this cannot be routinely recommended, as anti-androgen monotherapy is inferior to GnRH agonist therapy. So if we delve a little bit more into the intermittent versus continuous ADT, in 2012, almost 1,400 patients were reported with biochemical recurrence and a PSA of over 3 nanograms per mil 1 year after primary or salvage radiotherapy for localized prostate cancer, and they were randomized to receive intermittent ADT in monthly cycles versus continuous ADT. After a median follow-up of 6.9 years, there was no difference in overall survival, with a median overall survival of 8.8 years in the intermittent group versus 9.1 years in the continuous group. And again, quality of life was assessed at fixed time points regardless of the phase of treatment. This is a study by Crook et al. From Canada, which was reported in the New England Journal. Baseline quality of life scores were similar in the two groups for most items. For functional domains, mainly physical, role, and global health, the intermittent therapy group had scores that were slightly better than those in the continuous therapy group, but the differences were not significant. For items pertaining to symptoms, intermittent therapy was associated with significantly better scores for hot flashes, desires for sexual activity, and urinary symptoms, with a trend towards improvement in the level of fatigue. In a meta-analysis of 15 trials, which is published by Magnan et al., it involves nearly 7,000 patients and was published between 2000 and 2013. These were the papers. No significant difference was seen between intermittent and continuous therapy for overall survival, cancer-specific survival, or progression-free survival. However, there was minimal difference in patient-tolerated quality of life, and as such, even though intermittent androgen deprivation therapy was not inferior to continuous therapy with respect to overall survival, lack of significant improvement in quality of life and symptoms does not merit a change from standard treatment. And finally, in the article from Hussain et al., published in 2013, was a large phase 3 trial of patients with metastatic disease. Survival with intermittent ADT was not comparable to that in patients with continuous therapy. There were over 3,000 patients with a follow-up of 9.8 years, and median survival was 5.8 years for continuous therapy versus 5.1 years for those with intermittent therapy. Subgroup analysis identified that patients with minimal disease had a median survival of 7.1 years for continuous versus 5.2 years for intermittent. loss of almost 2 years of life in the intermittent group could not be ruled out. Therefore, continuous androgen deprivation was felt to be significantly better in the minimal disease group, with a 23% relative increase in the risk of death with intermittent androgen therapy. So based on that, one would have to say that this significant difference could translate to a 20% relative increased risk of death with intermittent therapy as compared with continuous therapy when you looked at them together. So I think as we look again at intermittent versus continuous, survival is worse in intermittent androgen deprivation therapy for patients with metastatic disease compared to continuous hormonal therapy. The lack of statistically significant inferiority of intermittent androgen deprivation does not equal clinically insignificant differences. And combined data from randomized controlled trials does not support a large or durable effect on quality of life. So if we accept that continuous is more than likely what we're going to need, then how do we address the hot flashes and androgen deprivation therapy? Over 50% of men will complain of hot flashes on ADT, and these and other vasomotor symptoms are due to hormonal withdrawal from decreased testosterone, causing a rapid disruption in estrogen and androgen equilibrium, which impacts the temperature set point in the anterior hypothalamus, causing the peripheral thermoregulatory mechanisms to be activated inappropriately. They occur equally with most forms of ADT except for oral estrogens. Clinicians should recognize the frequency of these side effects and screen all patients regarding these symptoms. In terms of management, what can we do? Well, one of the options is medroxyprogesterone acetate. And after 1 month in this study, and there's a number of studies on this slide, after 1 month, all groups had significant improvement in their hot flashes, with the greatest improvement being shown in the Abiraterone group, which was 94.5%, and the medroxyprogesterone acetate group, which was 83.7%. Because progesterone could interfere with ADT, medroxyprogesterone acetate is the gold standard treatment for ADT-induced hot flashes. What about during the hot flash treatment period? In this trial, there was 201 adverse events occurred, most commonly gastrointestinal disorders, vascular disorders including thrombosis, and hypertension and nervous symptom disorders including headache, anxiety, and memory impairment were identified. Another option is acupuncture, and this is one of the alternative remedies which have been studied. And what we're looking at here is there's a number of prospective studies which report up to an 89 to 95% improvement in hot flashes with acupuncture. The proposed mechanism of action is that acupuncture stimulates release of serotonin and norepinephrine in the hypothalamic regulatory system, which therefore modulates peripheral the autonomic nervous system. Looking at a randomized controlled trial published by Walker et al. In 2010, they compared 12 weeks of acupuncture versus venlafaxine in breast cancer patients on hormonal therapy with tamoxifen. There were 50 women with breast cancer on hormonal therapy with tamoxifen who were randomized to receive either of these two options. The health outcomes were measured for up to 1 year post-treatment. Both groups exhibited significant decreases in hot flashes, depressive symptoms, and improved quality of life from pre to post-treatment. These changes were similar no matter which treatment you were on. But by 2 weeks post-treatment, the venlafaxine group experienced significant increases in hot flashes, whereas hot flashes in the acupuncture group remained at low levels. The venlafaxine group experienced 18 instances of adverse events, including nausea, dry mouth, dizziness, and anxiety, whereas the acupuncture group experienced no adverse events. So what about ADT and bone health? Well, we know ADT accelerates bone loss in men. We know bone mineral density decreases by 5 to 10% at 1 year and begins within 6 to 9 months of ADT initiation. There's an increased bone turnover, which can result in an increased fracture risk. And there's up to a 21% relative increase in clinical fractures on ADT. The International Society for Clinical Densitometry guidelines recommend utilizing the fracture risk assessment tool released by the World Health Organization to determine fracture risk. For men with a 10-year risk of hip fracture, over 3% based on this tool, a baseline bone mineral density scan should be obtained before initiating ADT, followed by a scan 1 year or after 1 year of therapy for men on long-term ADT. What can we do to prevent this complication? Well, 120 milligrams of calcium and 800 to 1,000 international units of vitamin D have been recommended. No randomized controlled trials have been performed to evaluate whether supplementation improves bone mineral density for patients on ADT, but it is reasonable to make these recommendations. And now currently we may want to go up to 4,000 international units per day, which is actually the level recommended by the Institute of Medicine. There are other agents as well which can be used, which will include bisphosphonates, denosumab, and SERMs. So looking at bisphosphonates, this was randomized controlled trials of bisphosphonates have been shown to increase bone mineral density or reduce bone mineral density loss in men receiving ADT. Most recently, a 2013 study found the addition of weekly oral alidronate improved spinal bone mineral density by 1.7% compared to 1.9% with calcium and vitamin D alone. There was a systematic review and meta-analysis in 2012 of 15 trials, which included over 2,600 subjects who reported that bisphosphonates as a class prevented fractions and osteoporosis with a relative risk of 0.8 and 0.39 respectively. This was data from Neto et al. Published in Prostate Cancer and Prostatic Diseases in 2012. Looking at denosumab, it's a humanized monoclonal antibody against NF-kappa beta. And this cartoon shows you how it works. And it basically blocks maturation of pre-osteoclast to osteoclast and thereby prevents bone reabsorption. Now, as I've mentioned, it has been shown in a randomized controlled trial of 1,468 men to increase lumbar spine bone mineral density at 24 months by 5.6% compared to a 1% in the placebo group in this trial, which was reported by Smith et al. In the New England Journal of Medicine in 2009. Denosumab treatment also led to a decreased incidence of new vertebral fractures at 3 years, and the figures were 1.5% versus 3.9% with a relative risk of 0.38. Looking at SERMs, there are a number of them, and while SERMs such as raloxifene or teremifene have been shown to improve mean bone mineral density and reduce the incidence of new fractures by 50% compared to placebo in men on ADT, there was a statistically increased incidence of venous thromboembolic events with the SERM therapy, and as such, they are not FDA approved for the prevention of ADT-related bone loss. So looking at the NCCN guidelines, for men with a 10-year risk of hip fracture of over 3% based on the FRAX algorithm, the recommendations are what I've given you before, the calcium and the vitamin D, and either denosumab 60 milligrams sub-Q every 6 months, or zoledronic acid 5 milligrams IV annually, or alidronate 70 milligrams PO weekly. The higher doses of denosumab are included for those patients who have significant metastatic disease and usually castrate-resistant disease, although it does tend to be used for men who are also non-castrate by many urologists. So that deals with the bone health recommendations and where the land lies in that area. Next, I would like to move to the chemo part of this talk. And I would start by saying that ADT in the current era needs to be personalized for the specific patient. And there's a number of things which need to be considered, namely cardiac complications, obesity and testosterone, control of FSH, high volume metastatic disease versus low volume, docetaxel and significant LUTs. And all of these are factors which should go into any decision on the use and type of ADT. So let me go back to what has recently been found. We know the testis produces testosterone, and LHRH agonists and antagonists work there. We know the adrenal glands also contribute production, and anti-androgens have worked there. But more recently, we have discovered that prostate tumor cells themselves produce their own testosterone. So we have now 3 sites where we can identify production of testosterone. And these findings have led to the more recent anti-androgens and anti-testosterone agents, one of which is Abiraterone, which I've shown here on this slide. And you can see that it's a CYP17 inhibitor. And there have been a number of trials of it, and typical of the way drugs were developed over the last decade, we started at the very end of the spectrum, namely on patients who were castrate-resistant they had castrate-resistant prostate cancer, they had been through most of the therapies, and they were now post-chemo. And this was the patients who were included in the first trial of Abiraterone, which was COUGAR-301. And it was a successful trial showing a significant advantage for this agent. And then, of course, it moved into the pre-chemo area, still in castrate-resistant prostate cancers. And you could see here that there was an equally efficacious outcome in the COUGAR-302 trial. The second big agent was the anti-androgen enzalutamide, which is really a third-generation anti-androgen with three separate mechanisms of action. It was FDA approved in 2014, and the indications are in metastatic castrate-resistant prostate cancer with recurrence, or metastasis. And again, there was a post-chemo or docetaxel trial first. Then there was a pre-docetaxel trial, which was the the PREVAIL trial. And more recently, there's been the STRIVE trial where they compared it versus bicalutamide in men with castrate-resistant prostate cancer. The PREVAIL trial was recently published again, or there was an extended analysis of this published, and there was a reduced risk of radiographic progression by 68%, or of death by 23%. There was radiographic progression-free survival at 20 months versus 5.4 months for placebo. And there was an improved median overall survival. It was 35.3 for the treated patients versus 31.3 for placebo. There was also an evaluation of the longer-term efficacy and safety up to the pre-specified number of deaths in the final analysis. And as I mentioned, 20 months for the radiologic progression-free survival, 9 months for overall survival, and 4 months for safety. Adverse events included back pain, constipation, fatigue, and arthralgia. And then recently the STRIVE trial, which was just announced also within the last year. This was enzalutamide versus bicalutamide in men with prostate cancer progressing on ADT, 198 patients in each arm. PSA progression-free survival overall was 19 months for the enzalutamide versus 5.7 months, which was highly significant. And there were highly significant findings in favor of enzalutamide in terms of time to PSA progression, the percentage PSA response, the duration of radiographic progression-free survival, and the best overall soft tissue response. Exactly what one would have expected. This slide shows how the landscape in prostate cancer has changed since 2010. You can see it listed here. And along with new drugs has come new concepts. And one new concept is the question of should these advantages be applied to hormone-sensitive prostate cancer patients? And if so, which agents and when? So in order to look at this final part of this talk, we're going to have a talk about the CHAARTED data. We're going to look at the CHAARTED study, E3805. We're going to do a comparison with the GETUG-AFU study. And then we're going to ask the question of who really should receive docetaxel. Should it be the high versus the low risk groups? And we'll have a look at some safety and toxicity considerations. Looking at the CHAARTED data, we all know this data. It was presented by Sweeney at ASCO 2014. There's been a number of publications on it. And patients were stratified into extent of metastatic disease, age, performance status, CAB greater than 30 days, skeletal-related events prevention, and prior adjuvant ADT. And the randomization was to ADT plus docetaxel versus ADT alone. And the findings were really a major surprise for the urologic community when it showed that there was a significant survival advantage for those patients receiving ADT plus chemotherapy up front. It was a 790-man trial. There was a planned interim analysis at 53% of patients who met information. And in the January of 2014, there was a median follow-up of 29 months. There was 136 deaths, 110 with high volume disease for ADT, compared to 101 deaths, 82 high volume deaths with ADT plus docetaxel. So a significant advantage for the ADT plus docetaxel. And 83.6 versus 83.2 of the deaths were from prostate cancer. While overall survival was assessed in the subgroups of high and low volume, the benefit of this early analysis is more apparent in the high volume subgroup. Specifically, in patients with high volume disease, there's a 17-month improvement in median overall survival, with an increase from 32 months with ADT alone to 49.2 months with ADT plus docetaxel. Note that the survival curve split very early in the high volume group. In the low volume metastatic group, the hazard ratio were similar, but the curves don't start to split until much later, closer to 2 years. So this data is probably not mature enough. So if we look then at the GETUG study, and that basically really brings up a first question. We have this great randomized controlled trial from France and Belgium, which looked at the same thing, but it was negative. It did not show the same survival advantage. And the question that we have to ask is why? So if we look at some of the key differences between the GETUG and the CHAARTED data, this is a busy slide, but you see that there was more statistical power for the CHAARTED study. The Gleason grades are interesting. They're missing data on 1.8% in the GETUG versus 11.4% in CHAARTED. So known data may look worse. PSA data was clearly higher in the CHAARTED patients. The definitions for high volume or poor risk are different in the trials, and that is a fact that that needs to be considered in the design of all trials. Toxicity seems to be higher for the GETUG patients. The point being is are there more people who didn't receive full chemotherapy dosing, and could that have contributed to worse outcomes in GETUG than in the chemo arm? There's a shorter follow-up in the CHAARTED data. And the subsequent docetaxel story, we will focus on only those that progress to castrate-resistant prostate cancer. So you can see that, and we also see that subsequent treatments after failure may be different between these two groups. So the summary of factors that may have contributed to different results between the GETUG and the CHAARTED would include study size and statistical power, prognosis and staging definitions and disease risk and volumes were different, and the toxicity, particularly the toxicity, when you look at the deaths and the early discontinuation and the use of other subsequent therapies, these were different. So there's been some controversy in the field over whether giving docetaxel in the hormone-sensitive prostate cancer setting might be less toxic since it is earlier. But then again, maybe it's more toxic, and the publications with GETUG seem to imply that. But if you look at TAX 327 and GETUG and CHAARTED, which we shouldn't really do, but let's have a look at it anyway, there's a difference in the neutropenia, and neutropenia itself doesn't have major clinical implications, but when you look at febrile neutropenia, it is important, and it was higher in the hormone-sensitive prostate cancer trials than in the TAX 327 trial. We have to also remember that GETUG didn't allow the use of growth factors at the start of the study, and there was over 56% of the study had been accrued before it was brought in. There were 4 treatment deaths, and the Disease Safety Monitoring Committee recommended that GCSF should be used with declines in grade 3 and that resulted in declines in grade 3 to 4 neutropenia and also febrile neutropenia, and there were no more deaths. But the key conclusion is more a question than anything else, and that is, since there are earlier patients, why might we see more toxicity? What is the reason for that? And we see it here. And this was basically a study which was published. There's actually 2 studies published, which dealt with docetaxel in the castrate and in the non-castrate setting. And in one of the studies, there were 10 non-castrate and 20 castrate men with similar demographics. And clearance of docetaxel in the castrate men was 100% increased with a twofold reduction in the area under the curve. The authors performed the erythromycin breadth test, which indicated hepatic CYP3A4 activity for docetaxel metabolism was not different. So basically what this transpires to mean is that there is much more of the docetaxel which is kicked out of the liver in the castrate patients than there is in the non-castrate patients. And a 50% decrease in docetaxel clearance has been associated with an over 430% increase in the odds of grade 3 to 4 neutropenia. So what are the implications of these PK differences? Well, it may explain some of the differences between the trials, may explain some of the greater hematologic toxicity, but also some of the survival benefit observed in castration-sensitive compared to castrate-resistant trials. Why was there greater hematologic toxicity in the GETUG versus the CHAARTED study? Well, one of the questions that need to be asked is how many patients were non-castrate versus castrate in each trial. And in the GETUG study, 47% of the initiated patients initiated ADT within 15 days of enrollment. In the CHAARTED study, the patients initiated ADT at a median of 1.1 months after enrollment. So that would tell you that there is a difference in the patients who were castrate versus who weren't. Now, the recommendations are for the practicing clinician, they should consider waiting until 1 to 2 months after ADT or castrate testosterone levels have been reached before starting docetaxel. That makes sense because the toxicity is less. And they should consider using G-CSF at least for the first couple of cycles until the patients are castrated. But maybe we should also consider and ask the question that if the toxicity is greater, might not the efficacy be greater? And I did show this, I want to show this slide, the STAMPEDE, which was the third study to be published within a short period, showing the benefit, or looking at the benefit of early ADT plus chemo in the non-castrate patients. And you can see here that it supported the findings of the CHAARTED data. So I go back to the question that I just asked, and you see it here. How do we answer this question? If toxicity is greater with the use of docetaxel in the pre-castrate state, might not efficacy also be? And the answer is simply, we need a trial. And this is the trial which is currently enrolling. It is a phase 2 trial. It's only enrolling 50 patients. And we're enrolling men with newly diagnosed treatment-naive metastatic prostate cancer of all volume statuses. The primary endpoint is the proportion of men who maintain a PSA of less than or equal to 0.2 at 40 weeks on study. That's after 7 months of ADT. We will also look at a number of additional endpoints which are listed here. So finally, these are perhaps some considerations for the use of ADT. And I really want to focus at the very end of this slide that I have. And that's for patients with metastatic hormone-sensitive prostate cancer who are going on chemo and ADT. What would be the best way to give it? Well, if you want your patient to be castrated within very quickly, after giving, say, 3 or 4 cycles of docetaxel, then the best way to do it is with an antagonist, because your patient will be castrated within 48 hours. And if you're not doing it, then I think the options lie when people ask, should you use an agonist versus an antagonist? It very much depends on whether the patient has a pre-existing cardiac disease, whether the patient has higher volume metastatic disease, because both of these in the past and in a limited number of studies have shown benefit in favor of the antagonist. Thank you. I enjoyed giving this talk.